So the sound quality would be good, I guess. Yeah. So I am eager to take the time. The aim is to close. Yes.
Let's start the presentation today, the seminar today, and our presenter is Ochsner, and the word is yours.
Yeah, so thanks a lot for the kind invitation here, and thanks a lot to come to such a lovely city here, which I've been here several times, but I've never been here for more than 2 days. So this is the first time that I spent at least 3 days, if you count the first day, just the day when I arrived at 11:30, 1 day. Otherwise it will only be at 2 days, once again. But yeah, so thanks for inviting me and give me the opportunity to present, let's say, a paper that links to quantitative economic history. I know some people here already in the group that are also trying to dig into historical data, archival data, to tell empirical stories in the hope that we as economists or political scientists or people that are interested in the society can learn something out of it. And the hope is also, of course, for the project I present here today, that these insights are there, even though we are focusing on a small part of the world, which is a canton in Switzerland. I mean, people from the US would probably ask, why should we care about? But in particular, we should care about because the setting is unique. The data processed there, how shocks evolved and how clean they are and which data we have is also quite unique. So I really hope to make a contribution to understand much better why people believe in science or not. This is maybe a large claim I want to do, but this links to the title here, Progress Without Us. So we want to look about what makes people believing or acting towards technologies or policies that are meant to be better than others, or whether they do the opposite. And after something happened, they do not believe in progress in some policies, in some technologies anymore, and do not use them that often, even though history has told us that it's a superior way to follow these technologies. So this is what we're going to ask here, and we look in particular on the Spanish flu, and I use the term Spanish flu, great influenza, the 1918 pandemic, and so as the same word to refer to the fact that during fall in this particular year, a lot of people died of what was called then the Spanish flu. And we look about how mortality in the Spanish flu is then linked to a shift in political statements and also in health behavior. So this is what we are going to talk. The topic is quite urgent still now, or still if you go back some years ago to the corona pandemic in a sense. One can think about if a society observes that something happens to be very bad, maybe they will listen or trust more what maybe scientists, doctors and health ministers are telling us. But we can also observe if you just look on the media, on skeptics and so on, that also the opposite is occurring, that a part of the society becomes more skeptical of what the government is doing. They do not believe the so-called experts anymore. And maybe this is more than only a small size of people, maybe they are more, and maybe they matter for general statements. To think about how societies that is exposed to a adverse shock in a sense, how they react in terms of political domains and whether they follow certain rules that are otherwise seen to be superior. So this is just an example of people that showed their skepticism about all these policy measures during the pandemic 4 years ago. Of course, some of them or some of the claims here are valid claims, so we should be skeptical about what others are saying. We should be skeptical about what the government is claiming and so on. But the question here in our paper is more about stringently ask about if a health shock is occurring, how people behave in health political domains and policies and whether they use health technologies. So this is a more stringent story than just saying a lot of people died and I don't like the government that much anymore. It's more precise here. So what are we asking? And the main motivation is about, broadly speaking, is about what increased life expectancy over the last 200 years. And probably the most famous point of view is about that the sanitary conditions are going up. GDP per capita leads to better nutrition and so on. And this is probably the main driver of why we live now for 70 or 85 years instead of only 40 years. What is our life expectancy at birth? And then, of course, beside that, so besides sanitary condition and better food conditions in a sense, there are also other things that matters, and this is mainly related to science and technology. And one of the most progressive or most success story in the last 200 years is vaccination. And one of the most, or one of the first one is about a smallpox vaccination that leads to the die out of smallpox almost in the entire world. So if you look on the broader figures about, then you can still say, okay, a lot of people are saved due to vaccination campaigns, not only smallpox, but also others. But still, there is a lot of people, of course, in particular in the global south, that is not vaccinated at all, even though this would increase their life expectancy enormously if they would have access to it. So we link this to the story about when or which determinants should be there that the society is more willing to take up health technology probably to save life. And we look about whether adverse shock, in a sense, speed this process up or leads to the regression, so that people do not believe in health policies and health technology once they observe that the state probably cannot manage to protect people because they've observed dying people during the Spanish flu period. So this is in particular what we're going to talk about how a random health shock, and this is the Spanish flu, shifts attitudes towards health technology. We measure health technology use by a vaccination campaign, so whether children go to vaccination, smallpox vaccination campaigns, yes or no. We also look about how people think about health policies. And this is, we can do so because of our data set. I will come to that. And also we can make some claims about in which political domains people increase their mistrust against public authorities, and maybe in others not. I will talk about all these things here. This is exactly what we're going to talk about. And then we will focus on probably the takeaway about what to learn more about our findings so far. So a brief overview about the paper, and I make some claims already right now. And I just want to say, if you have questions, in particular, once you come to the data and you are curious about something, please ask as many questions as you can do. The entire paper is work in progress. We are not there where we want to be. I will also show in which domains I cannot deliver any results, but please feel free to interrupt me whenever you want. So our research question, straightforward now, is about, we want to look about how those places or families or people that have been affected by one of the most deadliest pandemics during the last 200 years, in a sense, how they change their behavior in terms of what they think about health policy and how they use health technology, meaning how they send their children to smallpox vaccination campaigns. And what we do, we zoom into a Swiss canton, the canton of Grisons, which is in the eastern part of Switzerland, contains of around 220 municipalities. So the sample size is not so large. If you look at the municipality level analysis, if you then look on individual behavior, of course, sample size is exploding. The good thing about that is that we managed during the last 2.5 years to go to local archives and get a really good sense about proxies to measure how people think in political domains at the locality level because of the election system there, and also about we have a turnout in smallpox vaccination campaigns, and we exactly know whether a person was dying according to the doctor because of the Spanish flu or because of other measures or other diseases or because of being sick without having the Spanish flu. And what then, yes?
I just want to ask, this is the only canton for which this data exists, or did you pick this canton for some reason?
We pick it for some reasons. I guess if you would go deeper, you will find other cantons. Probably you even find it here. I don't know. Here in Hungary, for sure, smallpox vaccination campaigns have at that time been all over, let's say, the Western world back then. And for sure, some transcripts are there, even if you go to the US, to the United Kingdom. The good thing, and I will come to that point, is about that Switzerland was not fighting during World War I, which means we don't have to distinguish flu deaths with casualties during the war, which is one point. The next thing is really about why we focus on this particular part of Switzerland, because the people of the canton have been asked whether smallpox vaccination should continue to be compulsory 3 years after the Spanish flu. And this was the only canton where they have this kind of stringent question about what people think about health policies and health technology. This is why we focus on them. But it will be doable with other cantons, but then we need another grant to do so, obviously. And we are still in the process to digitize individual data records here. So yeah, it's work. There was maybe another question. Okay, so then I will continue. So what we do straightforward is about we link in a different approach, but also in a cross-sectional approach, whether those places that were affected with health technology are more or less in favor for health policy and health technology. And our preliminary finding, or the preview of the finding, I think the finding I present today, they are fixed because they are stable, whatever we do, is about that if you live in a place with higher flu mortality, please, people do not like health policy measures at that much after the Spanish flu, where we don't find differences in sentiments before that. And people send their children much less to smallpox vaccination campaign if flu mortality was high. So this is the preview of our finding, which just leads to the title of the talk, in a sense, a progress without us, which means about if you observe in a community that something happened that is considered as bad, people do not trust the respective policy measures or technology measures that much afterwards. So this is not a progress we are thinking of. In a way, if you observe a health disease, then maybe you should care more about health measures, but it's the opposite. And it's maybe something outside of the ivory tower of research that fits to that. So there is a philosopher at the London School of Economics, John Gray, who was saying outside of science, a progress is simply a myth. And this is probably how ordinary people are more thinking about the world is not becoming better. And we are linking, let's say, a shock where the world truly shows that it can be bad to the fact that people do not believe in progress or science that much anymore. This is now an overstatement potentially, but we will have some results in the future slides. So yeah, some few words on the literature, but probably I should not spend too much on that. The data and the setting is more of interest potentially. First of all, they are now also driven by the COVID pandemic potentially. A lot of papers that were showing up in the last years that link Spanish flu mortality to some outcomes. Some papers are looking on inequality, so you can think about if part of a certain age cohort in a society is dying, this has consequences on income inequality and so on, which is documented in some papers. And other papers that look more political outcomes are mainly looking about whether higher flu mortality, in a sense, is good or bad for certain party, whether it's good or bad for the incumbent party or not. What I have to say here is, of course, that most of this paper, they face a data problem because they have to distinguish what are deaths because of the Spanish flu and what are other causes of deaths because of World War I and unobserved causes of deaths here. We don't have this problem because of our detailed data. Yeah, we also contribute to whether people are willing to take up technologies like vaccination and technologies and so on. And if you make an interpretation of our results, mainly in terms of why people turn out to be against certain policy domains or policy measures, health policies in particular, we also link to the literature of about how to think about salient markers after something became virulent in a sense. So the idea behind that is about that during times when there is no inflation, if you talk about monetary policy, nobody in the society cares about what the central bankers are doing because nobody cares. But once inflation is speeding up, people for the first time since maybe 10 years or the first time in their entire life are asking, what are these guys at the central bank are doing that we now have to suffer under inflation? And this is, there are papers out there that link to this kind of question, and this is also where we want to talk to in terms of if your municipality or your parents or your family members are dying because of the Spanish flu, and the state revealed that he's not able to manage the Spanish flu, that people don't have to die, people for the first time can start to think about what the policymakers or the so-called experts have done wrongly there. And this is then maybe the channel how to think why they became more skeptical among or against certain groups of people or politicians or certain kind of experts. So this is where we contribute to. The outline of the talk looks now much more than it is in particular, and I have to say this disclaimer here. We are still digitizing our data set where we can link deaths to family members to look about when the father died, where the children go more or less to vaccination campaign. We do not have data on these approaches here today, but all the other results that look on the municipality level outcomes, they are stable and fixed, and probably they would be more or less like this in the working paper, hopefully out quite soon. So this is what we're going to go over. The motivation has been done. The setting will come next. Then I like to talk about the data because I label myself as a quantitative economic historian, even though I speak to, let's say, political science and economic growth and behavioral aspect of society. But I really like to go to archives and look about which data are there. So I will bore you with a lot of descriptive statistics just because I like the data. But maybe it gives also an impression to you. We then talk about different outcomes we are looking at. So how mortality during the Spanish flu relates to policy sentiments, how it relates to health behavior, so whether children are sent to smallpox vaccination campaign or not. And I have some mechanism already here for you to think about what are the broader picture, how the drivers of the shifts are there. The setting and the background, so we focus on Grisons, which is the canton in the very east of Switzerland. It's a mountainous place. Maybe you do not know, but the World Economic Forum, for example, is taking place there in the city of Davos, and St. Moritz is also located there. So St. Moritz is potentially here close to the lakes, and Davos is somewhere here in the center of the canton. So this is how it looks. I already made some pictures how to think about why the setting is extremely good, and I have to tell you and I have to convince you about that. First of all, we get all the data we can add REMOF, so we know from the death register whether persons are assigned to die because of the Spanish flu by a local doctor. So we have detailed death information. We have smallpox vaccination, a campaign where we know the names of the children that should have shown up for the vaccination but did not, for example. And we have put, and we have a proxy also for the sentiments of people, because in Switzerland, in particular, also at the cantonal dimension, there were often popular votes where people are asked whether they are in favor for this or that policy. So there we have a statement what people think and whether they are pro-government or anti-government, in a sense. I will come back to that. Next thing is about one like it and one don't like it so much, but the good thing is about that we have small-scale political units. So our average municipalities is only 400 people, which means that if you observe that the family is exposed to the Spanish flu, we can assume at least that the entire locality knows that this person had died, because the places are often quite small. So we have only around 10 places that have more than 1,100 inhabitants. There's a bunch of places that have around 1,000 inhabitants, but the mean will be around 400. Yeah. Next is about how the flu spread in Switzerland. Is of less of importance here. So it started in summer 1918 in the western part, and then the main wave of the Spanish flu, like in other European country, was then in fall 1918. And then, of course, over the next months and so on, we always observe some smaller peaks in the death rates because of Spanish flu, but the major wave, as you will see, was in fall 1918. And if you look about the severeness of the Spanish flu, and these are the mortality rates per 1,000 inhabitants here in the canton of Grisons, and then we see that over the first 2 decades, in a sense, of the 20th century, the mortality rate was steadily going down here in this canton. And then it peaked enormously in this year when the Spanish flu have shown up. So over-mortality was around 50%, which is huge. So instead of 14 people that were dying, in this year we observed something like 22. So this is really an increase of 50% points in terms of over-mortality. If you compare that to the COVID pandemic, if you go to Germany and so on, it was around 7% or 10% in the most affected economies. So this is extremely severe. And if you look on the data, and I can show that this deaths occurred in a short period of time, within 2 or 3 months. So this was really an exposure to people to see, oh damn, something bad is now going on, and the state potentially failed to protect people. Yeah, data and descriptive. So this is where we wanted to talk about. So we have self-compiled death register data. I have some slides on them to learn more about them. We have information on that, on the name, on the age of the people that died, whether they died of the Spanish flu or not. We know the occupation and so on. And we have, as I said, information of the cause of death, whether they died of the Spanish flu. Then we have proxies for health attitudes and behavior. So these are the popular votes where people in some political domains ask whether you want to have this kind of health policies or not. And this is what we're using from the main outcome is the question whether people want to have compulsory vaccination, yes or no. But there are also other health policy popular votes that ask about whether the doctors should be sent to more municipalities, whether a hospital should be built up and so on. So we can link also to other such political outcomes. And of course, we have smallpox vaccination campaigns. So in Switzerland, yes?
Were also females allowed to vote?
Never before 1971.
Yeah.
So all
these are
voting,
the votes of males, right?
yes, so we only have the votes of males and only of the Swiss people. Yeah, of course. So the eligibility of a woman was not there. Still, this is something good or bad. It depends. So the good thing is about that the people eligible to vote before the war and after the war are the same. In many countries, you have the enlargement of the voting right to women after World War I. and many papers that look about whether the Spanish flu shifts pro-government vote shares and so on, face the problem of that before the war, in a sense, only men were allowed to vote, and after the war in Germany, also the women are allowed to vote. The good thing is that we don't have this problem here. The bad thing is about that we cannot really pin or rule out one channel that may hurt us, but I will come to that. Yeah.
I would be very interested how much the fathers in the beginning of the 19th were, deciding about or thinking about what to do with the children. I mean, I just know about some studies that say even today, mothers are more involved in healthcare, whatever questions of children. So it would be really good to see some link between the opinion of fathers and the actual.
Yeah. So of course,
what
I
happens
mean,
to children.
we don't have the voting right for the women here, and even if you would have it, we would not have better a women vote in a different way than the man, because it has sum up among the gender. By the way, only Austria in the interwar period have summaries of whether of the vote shares by gender, but this is one of the only countries that I know. This is a period also where we don't have a survey data, so to make a sense of what is the perception of fathers or mothers that are have been exposed to dying people within the family is hard. But, and this is why I made the note here, we have also the individual data, so we know whether a women family member was dying or a man family member was dying, to look about what happens to children within this family. So then maybe we can go towards this direction, even though we probably would not be able to talk about that channel. So whether, I don't know, you can think about if the man is dying, the woman is more stressed potentially to find a job, to work as well, and then this causes some outcomes that they are not willing to send the children to, or not able to send the children to the smallpox vaccination campaign. So this is the problem we have, but this is a good note. But generally, I think we have heterogeneous treatment effects, I will also show. So if women are dying, this does not matter so much in the turnout of health behavior or what people are voting for, compared if a man at the same age is dying. So the man that dies, it matters more for a shift in perception of health technology and health behavior. But this is only because of a heterogeneous treatment effect, which you cannot really say what is the mechanism behind it. But yeah, I will also touch this, but only touch this today. So we have this smallpox vaccination campaigns that started in the 1860s in Switzerland. Most of the German-speaking cantons in Switzerland have had a compulsory smallpox vaccination, which means that children were expected to go to the vaccination campaigns. And what happens in Grisson is that a group of people were thinking, oh, we don't like these compulsory vaccination campaigns anymore, we should skip the compulsory part of it. So this is why for the first time since 50 years, and only in the canton of Grisson in a sense, people were asked whether they want to continue to have these compulsory vaccination campaigns or not. And this is what we use as one of the main outcomes. But what's going on is about that every second year, cantonal authorities are reaching out to the municipality. They have a list of all the children that were born within the last 2.5 years that should be vaccinated for the first time. And at the age of 14 to 16, so some 14, 15 years after the first vaccination, there is the revaccination. So children must get vaccinated twice. And we have all the data about who should show up in the first one, who should show up in the second, in the revaccination. And of course, we have a bunch of other data, but these are straightforward data like census data and so on to look about confounders or local characteristics. So let's talk deeply about more details about the data, which I like. So 30 minutes are over. So I hope to end this part of the data within 8 minutes at the maximum, that we have someone is not believing me. Potentially, so that we have time for the results, which are striking, I would say. So this is one of around 10,000 or 11,000 death register that we digitized. So we went to the archives and digitized when the person was dying, and all is written down in am 17. November 1918, so in the year 1918. We also know the name of the person, which would stay here, but I will not show it to that. But the name then allows us to link the name of the deaf people to the names of the children that are visible on the vaccination campaign paper. So whether they should show up or whether they showed up for the vaccination or not. We also know the cause of that death here. So this is a person that died because of the Spanish flu. We know that she was a farmer, that the person was a she was not married, and so on. We know the place, we know the occupation, and so on. We also know the age of the person. So this is all the information that we digitized and that we use then for further explanation about how death in the Spanish flu causes some shifts in health behavior and statements. If you look about when mortality in the canton of Grisons is occurring, then we see a more or less stable death pattern in a sense. And all the black colored people here are the people where the death register here is claiming they died because of the Spanish flu. And what we see here, there are some few deaths in late summer in 1918, and then it really peaked in October, November, and December of that particular year. And then you see that the flu waves were not so enormously afterwards anymore. There were still some officially quoted people dying because of the Spanish flu. You also see a certain peak here where only a few people are mentioned to die because of the Spanish flu, but we do not know whether the doctors always get at the right cause of death. And this is why we also make robustness check in terms of we only look in our main specification on people that died because of the Spanish flu as a share of total population during the main period of the Spanish flu. But then we also look on overall mortality. And then we will see that mainly the Spanish flu people affects the outcome, not other deaths. So these are the data, quite granular, and we have them digitized for only 5 years in a sense, in the hope that the referees will not ask for more. But this is what we have now. It can always be. So the problem here, I mean, for us, it's not a problem because we think we don't have to care about, but what many papers are doing, if they look on Spanish flu, they calculate something like overmortality, or they know what is the expected number of people that die in a certain place, and often these are larger places with 10,000 of people. So then random deaths are cancelled out in a sense. But we have small places. Some of them have only 100 people in this place, which means that we do not maybe observe even in the high period of the Spanish flu any deaths there. So we cannot calculate a number of overmortality or excess mortality because we do not know the baseline. This is driven by the small sample size. But if you would add 20 years before that, we can estimate what is the likelihood of that even in small places, a person will die in a certain year, which we cannot do if we have only 4.6. But I think it's a minor since we look on shares and not on overmortality or excess mortality.
Do you observe smallpox mortality?
I would like to say yes, because there are none. So one death end in the evolution of the data collection part. It's really like a Darwinism approach here. So we try to think about what would other interesting outcome be, is about whether there were more cases of smallpox outbreaks. But after World War II, there were only 3 cases of reported smallpox outbreaks. Most of them were imported from the Balkan, in a sense, so we cannot make an empirical story. There were no deaths because directly linked to smallpox. I think in Europe, you don't find them so much in the 20th century. There were some outbreaks after World War I in Yugoslavia. I don't know how the picture looks if you go more to the east and so on. But in Western Europe, it was done probably, and it was a success by these vaccination campaigns for sure. This looks quite different if you would go 50 years before that, obviously. So if you look on the effectiveness at the regional dimension, then the best thing would be about that the flu deaths are falling from the sky. So whether a place was heavily affected or not is fully exogenous. This would be the dream, which is hard to prove, but it's not really true in our case. But what the good thing is about, if you look at the municipality map here, it's a kind of a heat map. Then you see that heavily affected places are neighboring almost non-affected ones. And if you assume that neighboring places have similar characteristics, maybe not on the local workforce population, but at least on accessibility, but also local workforce population and so on, we can hope that we can make a causal claim here. But this is something for the future. So what you see here is you see that if you look on mortality only during September until December, these are overall mortality, so the entire bar here, which is huge over mortality, so by 300% in a sense. So instead of having 110 deaths in the canton, you reach a number of 400. So over mortality is 300 to 400% higher there at the monthly basis. So this is huge. So the church bell rings 4 to 5 times as often during this month than we would have expected given the death rates in the past. So, and the good thing is about the heavily affected localities are bordering almost no affected ones. And if you look here, we have some localities where up to 9% of the local population were dying only within a couple of weeks. And the outlier here is for Kalfreisen, where 9% of the population died within 4 months. So the locality of Kalfreisen is quite small. It has 60 people there, but 7 died. So this is huge in terms of to think about how a locality, a small-scale locality, probably only with 10 families potentially, how they were affected. And of course, we have around 40% of the locality where no deaths occurred during this period. Also, even if you look on flu deaths or overall mortality here. The next data set is the popular votes. Here, we digitize all the popular votes in the time frame from 1900 to the 1930s, in a sense. We know the turnout, we know who's eligible to vote, only the men are eligible to vote. And we also know, of course, the political domain of the popular vote. So we can say, is this a domain, or is this a popular vote that deals with health policy, public finance, technology, education, reforms, public property, and so on. And then we can really look about in which political domain flu effectiveness shifts the perception of people against the government. And against the government means whenever there's a popular vote in Switzerland, and this is still true today, there's a popular vote where people are asked, do you want to have this or that? And the government often made a statement in terms, dear people of our canton, please vote in favor or against this claim. So the government have a clear agenda, and the government makes a public claim what people should vote for. So we can also look about whether people in more affected places became more pro or anti-government, interacted with a flu mortality before and after the Spanish flu. This is what we will use then for the channel, a discussion. So the graph that you see here has nothing to do with our results in a sense, because it just showed the pooled at turnout. You see that at the beginning of the century, around 40% of the people go to vote in these popular votes. The turnout is larger in parliamentary election, but not in these political popular votes that people ask whether you are in favor of something or not. This is slightly growing. What you maybe can also see is that at the beginning, people were more in favor for what the government is aiming for. And afterwards, it's maybe not so clear anymore. But this is not the main story. The main story is really about, is there a feature if we link that to overall mortality? This is just descriptives. If you go to smallpox vaccination campaign, we have two kinds of sources, and these were ugly jobs to be digitized, and it took us probably 2 years, not on a 100% basis, but always working for a month on that, even though we also used research assistance for that. So the easiest way was if you find something like that, and these are the district overview, where we see all the localities or municipalities within the certain district. And we see about what is the number of children that should be vaccinated according to the age they have. We see whether they showed up or not. And if they do not show up, we see whether they are excused, so that the mother maybe send a letter to someone saying, hey, my child is sick, he cannot come to the vaccination campaign. Whether the child was unexcused by not showing up, or whether the local doctor was claiming that this child that was not showing up belonged to a real vaccination skeptic family. This is then mentioned here, and there are only a few, but this information are there. And then we also know other reasons why the child is not showing up. Maybe the child can die, and then he's not eligible to be vaccinated, and this information we will get here. In other years and in other localities, we don't have this overview, so we quoted them based on the papers of the local vaccination campaign, where we know the name of the child. Is here. Sorry. Where we know the name of the child, we know the name, the surname, and the first name of the father, the first name and the surname of the mother before she get married, and we also know whether the child was vaccinated. We know the age of the child and the cause if not vaccinated. And for a subsample of the entire canton, we digitize this entire name list that allows us then to link a family death in the Spanish flu to the behavior in terms of smallpox vaccination behavior of children after we observed that family members are dying. And since we also have a panel there, we can also do a definitive. There was a question?
Yeah, what happens if a family with children actually migrates out?
So the question is when it migrates out. If they migrated out before the list was fixed, then we do not observe them. Yeah, this can be correlated with flu mortality. As said, if it would be like this, but this we cannot prove. If a child was part of the list and the authorities have the information that the child is not here anymore, then we have the notification here that the child is in, I don't know, in Schlaunis or something like this. So we know in which places they are. If you go to the individual data set, we go to the municipalities and look whether this child is vaccinated there. We do not follow the children that leave their canton. And of course, maybe we can, it's maybe hard, but it's not worse. It tends there are not so many. So if people leave a certain place, they go to the cantonal or they go to larger cities close by. Some go to Zurich, so these are few. Some go abroad, and we have no chance to follow them. But it's not worse in terms of how many there are and what is their cost to find out things. But we have information on this.
Do you have information about the outflow migration? I mean, in canton level, that is it a problem or?
So
It's small level that you don't have to care about it, but it's.
Yeah, so population is relatively stable, while the rest of Switzerland is growing, which just means that in particular on the countryside, people live to larger places and to places where industrialization has speeding up. So people tendency people in average are leaving this part. Not at a huge amount, but this may be the case, yes. Anecdotally, before they build a family, before they have a family. But after they are vaccinated, by the way, at the age of 15. Yeah, we have not made any thoughts on that, how this can bias our results. Yeah. But a migration to these places, despite the few larger cities there, is not a problem. So almost nobody is coming from outside and goes to a agricultural-based mountainous municipality. This we can exclude, and we would have this data by the way. Okay, so, and this is a smallpox vaccination behavior. Now I have really to speed up. Thanks for the question, by the way. So what we see is around 85% of all the children get vaccinated, and this is not really shifted with the period of the Spanish flu in average. But the aim is not to see a global shift, it's more about the higher mortality is there, whether this shapes then vaccination behavior. But at the aggregate level, you can say vaccination has never been so high in these years where we have the data as in the first vaccination campaign after the flu. So this would say the death rates was good to shift, to increase the vaccination, but you will see the opposite if you link it at the municipality level to that. And then we also see that, of course, around 15% of the children were not vaccinated, and the majority of the non-vaccinated children, in particular in the beginning of the period, were excused by the parents not to show up. But this is then growing more enormously than the other one after the Spanish. Yeah.
What about the sanctions? If the parents were not showing up, and whether these sanctions were
absent. Were absent. So we studied all the newspapers, and we studied the political claim of the government when it comes to the popular vote about whether compulsory vaccination should be continued or not. And the cantonal authorities are saying then, hey, dear people of our canton, you know that we say that the vaccination is compulsory, but we do never make a sanction or ask for a fee if you don't send the children.
And
so at the end,
what about peer pressure?
The peer pressure is potentially there. Peer pressure is huge, I would say, and this you see in our confidence bands. So the estimates are much precise if you look on what people vote compared if you look on the turnout in smallpox vaccination campaign. One of the idea why noisier results are there in vaccination campaigns, even they are stable, is about things we cannot observe, peer pressure. Yes.
About schooling, so is it not compulsory to get the child vaccinated to attend public school?
Still possible to attend it. So it was not a sanction at all, and this is the claim of the government in 1922. I do not know whether they were sanctioned 20 years before. That's right. But it was not sanctions as of now, but the right was there that the government had the power to do so, but they've never done it. At least this was the statement in the popular vote by the government to say, hey, look, there is no need to be harsh because we want to have a secure a vaccination campaign here. And as of now, we have not built or handed out fees to people that do not comply. Okay, so now I have 10 minutes. It's now I really talked a lot. So these are just local characteristics in a sense. What I want to highlight here is we have 3 different languages here we all control for, but I want to say that if you leave out the 2 largest cities in the canton, average population size is only around this 428 people per locality. So this is why we say people should know each other and know whether people died in a certain period of time or not. Let's talk first about the sentiments, and in a sense we just do a cross-sectional OLS regression. where we want to see whether people in these popular votes, where people ask whether we want to continue compulsory vaccination, whether they are in favor or not for compulsory vaccination, which is the Y variable here. And we look whether in places with higher flu death, whether people are more or less against compulsory vaccination. And we control for all the observables that we have. Of course, the world may be endogenous in terms of the best thing would be that the flu deaths fall from the sky and neighboring places are randomly having high or no death rate during the Spanish flu. This is not fully the case. So what we observe is about that in larger places, in more Catholic places and in places with higher household sizes, we observe more flu death. This is which is a problem, but we then make sample split and robustness exercise, and all these variables either way are included in the regression as controls. But we can largely exclude that these variables that correlate with flu deaths, that they drive anything of our results. And yeah, this is what we have done. The most impressive thing is about if we look on health measures before the Spanish flu. So these are mainly popular votes before the Spanish flu that deal with health policy questions. And these are not correlated neither with flu mortality during winter of the flu year, nor with overall mortality in the last 4 months of the flu year. So if you look on health statement of the people in a sense, these are uncorrelated before the Spanish flu with overmortality or with flu mortality. And even better, I would say, the smallpox vaccination or the vaccinated children or the children that do not show up is uncorrelated before the Spanish flu with the mortality during the Spanish flu. So the statement here is mainly about there is a shift after the Spanish flu in what people think about health policy and health behavior, but behavior and statement in health policies is uncorrelated with flu mortality before the flu is showing up. So then it's really about exogenous to health behavior and statement, how overmortality is. If you look on a graphical composition, then it's what we said. So we see about the more people that die, independent whether we look on flu deaths or on overall mortality as a share of total population, we see that pro-compulsory vaccination vote share is going down. So you can think about if you increase the death rate by 1%, the pro vote share for compulsory vaccination is going down by 3 to 5%, depending on the controls. So this is just a graphical interpretation. If you look then on regression outcome, it's similar. So if you don't include any controls, we see that a 1% increase in the share of flu deaths reduces the pro-compulsory vaccination by more than 5%, which is relatively huge. And also in terms of standard deviation. So one standard deviation increase in flu deaths share reduces the vote share in favor for compulsory vaccination by more than 3 standard deviation. This is quite huge. However, it becomes smaller once we control for district fixed effects. And I just want to say that we have 218 municipalities here, and we control for 34 district fixed effects, which means that we really compare only neighboring municipalities with each other that have around 7. So each district has in average a little bit more than 6 localities. So it's really about we compare neighboring places that are differently affected by the Spanish flu. And then the coefficient goes down a little bit, but it's really stable. And even if we control of a lot of confounders, it remains stable. Yes.
How do you exactly understand that there are three?
They are spatially clustered so far, but we make a bunch of other exercises with different spatial. And even if you just use over standard errors, which is maybe even the most conservative specification, by the way, it's stable. Maybe we use some stars if you have more demanding specification like here, but this is stable. It's more a measure or it's more an issue if you look then on the vaccination campaigns that are more noisy. But here you cannot keep whatever you do. Interestingly, what we do here is we look about who died because of the Spanish flu, or what is the share of people that died because of the Spanish flu. And then we also controlled for the other deaths during the same period that were not dying officially because of the Spanish flu. And what we see is the estimate or the coefficient here is almost not affected. So it's really stable. And we also find a negative coefficient of general mortality. And this is reasonable in a sense because not every death person was detected by the doctor by the right cause of death here. Yeah. And if you look at the extensive margin to compare places with Spanish flu and without Spanish flu, we find a decrease of a percent point, a decline in poor vote share if you go from a non-affected place to affected ones. And even in the intensive margin, we find similar effect, maybe a little bit more noisy but large. Results are stable, so whatever you do, and I think inference is not sensitive to the specification of the standard errors this I've mentioned. Now let's jump to the vaccination behavior, where we just want to look about what is the share of children that is vaccinated, link it to the death rate during this period, or the flu death rate after the Spanish flu, and control for a lot of things like local characteristics, district fixed effect, interactive behavior fixed effect, and so on. So we do this difference in difference study. And then we can also claim about, okay, whether we can find a pre-parallel trend here, which I already mentioned here is about that vaccination behavior is not correlated with flu mortality. So we should have or expect also in a definitive setting that we have a pre-parallel trend here. So if you look to the outcome, and this is what I make the disclaimer already before, the results are noisier here because many things that may determine whether people go to vaccinated or not are not observable, like social pressure, the teacher that is saying you go or you do not go. So this can make a thing, this can make a decision that they cannot observe. So this is the main feature here. The results are more noisy, but I think are still stable enough to make a general takeaway. What we see here, if we take all vaccination, here we only see the first vaccination of young babies at the age of 3 months up to 2.5 years. And here we see the behavior of revaccination. I see that time is almost over. Can I have 5 minutes extension, or is this fine? Okay. And what we see here is about that, I would say we can claim there's a parallel trend that is going on. So the differences, if you look at this event study design, the differences before the Spanish flu in more or less affected places, so this is a coefficient plot at the end, do not differ, which is great. And if anything, it's slightly more different in the revaccination behavior, where we also find higher results. And then what you see here, everything is standardized to be 0 for the last year where we have vaccination data before the Spanish flu. And then each point here are the pooled vaccination campaigns of 2 years, simply because we pool to tell a story because of the huge variation we have. But I think this is a fair way to do. And what we see is about that throughout the next 6 vaccination campaign until the early 1930s, we see a decline in vaccinated children in more affected places by the flu deaths. This is driven by both first vaccination and the revaccination, even though the picture is more precisely estimatable for the revaccination. But if you would pool that here into one coefficient, you would also have significant results here. So it means that the more people that die, or if you have flu deaths in your locality, afterwards you send the children less to smallpox vaccination campaign, given the differences before. But the differences before are almost 0. And this is the same if you put that into a regression table. What you see here mainly in column number 2 is about the coefficients that you have seen here in a sense. So here we look about what is the share of vaccinated children and link it to the share of people that died because of the Spanish flu. Then we have also a minus if you restrict our sample only to the years until 1930, a minus a 3% decline in children sent to compulsory vaccination. The mean of the dependent variable is around 87, meaning 13% of the children do not get vaccinated. And if you have an increase in flu deaths by 1%, this then drops by around 3%. So it's still quite huge. And also, yeah, in terms of standard deviation also there. And it does not affect our coefficient. And maybe the most easiest interpretable coefficient is here the extensive margin, where we just compare places with and without Spanish flu deaths. And there we see that in average, places with Spanish flu deaths decreased vaccination rates by 4% after Spanish flu, given the differences before. So it's relatively stable, and the same story here. We also find a little surge or increase in people or families that are classified as real skepticism against vaccination, but these results are less striking and the sample size is small in terms of who belongs to that. Results are stable to the same specification we have discussed about, and also to the standard error clustering and so on. So let's have 2 minutes on this is what I said. So we in the future also have this individual level outcome where we can link the family names and so on to families and look whether a family member died, whether these children are then sent more or less to vaccination campaign. And we can even do that with children at fixed effects, because if a child was first vaccinated in this period, he or she should go to the revaccination after the Spanish flu. So we can even look on within child fixed effect, whether dying of a family member affects the same child and going to vaccination campaigns or not. We are digitizing this data since last fall. Somewhere in 10 years it will be ready. Last but not least, this is the last real slide I want to talk about this. We coded all these popular votes according to the political campaign. And we know that when there is a popular vote, the government always states, please vote in favor or against some reforms. So we have a perception whether people are more pro or anti-government, and we look in which political domains people shift their anti or pro-government behavior. And this is the outcome. So behind each of these terms here, if you see an economic policy, these are a couple of popular votes that deal with economic policy. And you see the coefficient plot here, which is the difference in difference coefficient that looks whether people in more affected or less affected places are more in favor for policy reforms in terms of economic policy, what the government wants before and after the Spanish flu, given flu mortality. And what we see here is that in general, if you take all popular votes, people do not have a shift in their government view of policy. So they are, in general, people in more or less affected places became not more pro or anti-governmental if you take all the elections.
Does the composition of the government change?
Not in terms of party, in terms of people, yes. So it's Switzerland, so they have this concordance, meaning that the largest two parties are sharing their seats and so on. But we do not control for that yet. So in general, the viewpoint in favor or against the government does not change. But if you look to some political domains where we can quote the popular votes, then we see that people became more anti-government in terms of the reforms that want to introduce new technology. I hope you can see the confidence band also behind. It's the lean one plot that looks easy going for a paper, but here it's maybe not so bullish, I would say. They are general against the reforms the government wants to do in health policy, and one of these reforms is the vaccination campaign, and they are against the reforms in education. And the education reforms are often whether a new gymnasium should be built, whether the years of schooling should be extended from 7 to 8 years and so on. So these are the kind of questions. So if you think about these domains, people become skeptical against science or progress of society. They do not shift their view on public finance issues, whether wages of teachers should go up and so on. And they want to have more economic freedom, more than the government. Yeah, so they support pro-economic freedom policies. And all these shifts and results are not largely driven by a shift in net turnout in these respective domains. There's a question.
Yeah, maybe I'll let you finish and then.
Okay, so this is the future. We have also analysis that we find that we have the characteristics of the deaths. So we know, we see that if a man died compared to a woman at the same age and also on, men matters more for these outcomes that we find. The age group that matters the most is the age group that was also the most affected by the Spanish flu. So people aged between 40 and 65. And yeah, what we also find is that the higher the socioeconomic status is, the higher the effects are. So meaning if a farmer is dying, entire effects on voting behavior or smallpox vaccination campaign is not so affected. But if industrial worker or carpenters or the teacher is dying, then you have higher effects. Yeah. So to conclude, we have here a study that has granular data, precise data, to say something about if a society is affected by a health shock, adverse health shock, how this society shifts their behavior towards health-related policies and hence health-related behavior by looking on popular votes and smallpox campaign. And what we find, surprisingly, is that life expectancy or something like this is at least not driven by observing the badness of life or some risk in life, like health shock, and then appropriate behavior that is driven by science. It seems to be the opposite. People became more skeptical against health technology and health policies in a sense. So yeah, this is as it is. Sorry for stealing you 7 minutes over time, but thanks for this lovely discussion here. And yeah, I can stay here also longer if you want, and some can. Thanks.
Small question. So have you checked the social economic background or education level of these areas? Because I just saw a presentation about the COVID effect in Hungary just 2 days ago, and they showed that there was really a huge heterogeneity for the morbidity rates and mostly affected East, North Hungary, especially Roma population.
Yeah, I can imagine. Yeah. Like in the Czech Republic as well. So
Okay.
yeah. So we do not have information on the education level of people. According to the death register, we only have the occupation. Of course, if someone is a teacher, a priest, or so on, or a lawyer, we can assume that he's educated. A farmer potentially less so, in particular the small family farms that we have. So this is the story we want to tell and that we can say. But just look at the figures. I mean, it's an agricultural-based society, so the share of agriculture is about at 70%. So at the end, we have 20 municipalities with a reasonable industrial share. The rest is almost purely agricultural.
Still, the socio-economic background can be different. Like in Hungary,
Yeah.
there are many villages also in Western Hungary. So the COVID actually had very, very different effects, and also the vaccination rates were very different, even for villages.
That's right. I mean, we do this with this looking on the occupation of people, which we have the occupation, as I've said, shown you in the death register. But at the end, we do not know whether it's a rich farmer or a poor farmer. This is what you care about. But I'm probably somewhere in the church book, it would be the donation of the farmer, and then you can rely that is it a rich farmer and the other one not. I cannot think about now how to find out this issue or to be on this data. But yeah, we know the occupations.
Education level?
We don't have education level. I mean, we have education. I mean, schooling was compulsory. We also elaborate since people, and now I can use it. So since people in more affected places where we are. Since people in more affected places are, so it should be here, okay. Since people in more affected places are against education and the effect is huge, it's -6%, more anti-government, what the government wants. The government often wants grow something, enlarge school years, build a new gymnasium and so on. So since we see this huge effect, we also have made a picture, and here one is missing, so some of the slides are just produced before that. So since people are against educational progress or reforms in a sense, we can expect that maybe children go less longer to school, in particular they do not go to the gymnasium if you observe higher mortality rate, even at the local level or within family. So we digitized or we make photos of 500 pages of school records of the classes that finished the gymnasium. We have there the names and the locality where the children came from, so we can also link to that to see whether this really reduces education of the people and not only the perception on education in the place. But at the end, I can not think about the source that can really say the socioeconomic status or the clear education level of the people, unless they are a farmer versus the priest. The priest has studied something and the farmer probably not.
Do you know the household size?
We have average household size only,
Because
but not with the death register data. This we do not know.
because this could be a driver. I mean, I don't know whether household size is correlated with the socioeconomic status or not, but you know, household size definitely would correlate with the spread of the flu, I'm guessing.
This is what I said. So household size is something that is correlated with flu mortality. Yeah.
But if household size is also correlated with socioeconomic status.
With socioeconomic status, with the number of children, and with farmers, so everything is here correlated. So
That's a driver. So household size could be also a driver. So that's not really good working for you because you know but the thing I was really thinking about is what makes the flu spread? I mean, why do you have some settlements with more flu and some with less?
yeah, exactly.
That's your main question, right? So
Yes.
So you're claiming that it's random, which is nobody will use, but
No,
this is
I
what you want.
not a big
This is
deal.
what you want.
This is what I want, but it's correlated with population size of the people, with share of Catholics, and with household size.
Yeah.
This is what it's correlated with. That's a problem. Yeah, but it's not correlated with pre-flu health statement. It's not correlated with pre-flu
Well,
health
if household
behavior.
size correlates with socioeconomic status, as the
Yeah.
Peter was saying,
Yeah, I agree.
then that's you know that's a covariate or a variable that you should worry about.
I agree. But even if this variable is correlated with things, it does not correlate with health behavior, and it does not before the flu, and it does not at the municipality level, I should say. At the individual family level, I'm not sure. I mean, we know how many children a family has because of the smallpox campaign, but we don't know whether the grandmothers are still living in this in this household or not. There you can have a guess or say maybe can do something on whether a certain person lives in a large household, at least whether a certain person that died within a household with many children that are visible in our smallpox vaccination campaign. Otherwise, I do not know how I would link individual at death to the household size. We don't have this data. But the main argument is then really, and it's not polished here in the presentation, I agree.
Oh, that's nice.
But so the behavior in health policies of people think and vote for, how they send their children to smallpox vaccination campaign before the Spanish flu is not correlated with local characteristics and with overmortality during this period of the Spanish flu. So this is maybe, if you would have a key assumption of our identification, this would be that. But people like you can always kill us. I agree. Sure. Yeah.
Well, at that time, government and health policymakers had nothing to know about what is the cause of the flu, and they had nothing to how to cure it. And this was the same for the population, right? So then
Yeah.
they are in the, so to say, in the knowledge space. And what to do, what is the rational behavior, simply just make a scapegoat. Something which coming from the center, something which coming from the, so to say, from the government, let's just reject it. And that's the only way how to make your story, because we have nothing to know about, we do not know anything about the way, what was the driving of the contamination. And it's even impossible to make our knowledge back to that structure and to give some structure explanation for all this, what you are doing in a so-called reduced form way.
Perfect in a sense. I mean, it's not so far away from some of the ways we are thinking it. So what is eminent for the people that are affected, they see that the government failed, independent whether they know what to do or not. So why should the government know it better if it comes to vaccination campaigns? So this is our interpretation potentially, and this is very well explained by you now. It's not per se true that the government has no clue about how to reduce the spread. So there were also the duty to not go to church, even though the Catholics say now we have to go to church to pray that we will not die, and this is then correlated to Catholic mortality. But there were some policy measures. There were the police. I mean, the newspapers are dealing with that, and they are talking about this clash between the government in prisons and the Catholic Church. The Catholic Church wanted to operate the church, the government wanted to close it. So a sense of how to stop the spread was there, and also if you look at all the picture, they are also wearing at face masks and so on. But for sure, it was not really understand how this is affected and so on. But some measures were known, and they were also tried to implement here. Restaurants were still open, but dancing was forbidden. And there was one particular girl that was caught by the police 7 times because she was dancing. According to a cartoon I found in the archive. But there are not so many reports on the policies during this period. But this is one of them that they sentenced a young lady that probably was not seen as a behavioral well potential in general. But yeah. Okay.
And
Yeah.
question about the, is it possible to
And thanks for those that stayed until now. That's great. And maybe this may be also an opportunity for those that want to leave. They are caught, they always leave. And thanks for staying 20 minutes longer.
Thank you.
Yeah. Sorry.
I will be short. So my question is whether this empirical analysis can be reproduced using Sweden data. And I'm asking about Sweden for several reasons, very much affected by northern countries. But besides that, Sweden treated the COVID pandemic differently than other countries.
Yeah.
That's one reason. Another reason is that Sweden, similar to Switzerland, was neutral.
Yeah.
during the
All right.
First
Fine.
World War. And culturally, it's very different from Switzerland. It treats its citizens as adults, or at least this is what I know from the COVID treatment. So I wonder whether your beta parameter is still negative if you move from Switzerland to Sweden, and do the analysis for.
Yeah, so this I can obviously not say. What we make, and we're not sure whether they were part of the papers, we also looked on Swiss case and the COVID mortality to popular votes that deal with COVID policy. And the correlation is really weak, but also over mortality is small. So COVID is maybe not the guidance because variation is smaller. There are studies out there that look at district level in the United Kingdom and find, at least storytelling-wise, less identified for COVID, similar patterns, so that the more COVID tests there are, the more skeptical people are against health policy, the less they show up to some vaccination campaigns. So it seems that things like COVID over mortality is correlated with lower COVID vaccination. And I guess this is also the case in other countries because There are underlying characteristics like socioeconomic status of people, whether they are Roma or Sintis and so on. They probably, the spread was higher, the death rate was higher, but they also do not go to the vaccination campaign. So correlation-wise, I would say there's plenty of anecdotal evidence also for COVID around the world that would support diseases, but less identified. Going to Swedish data, and we have discussed about that. So my sense is about these vaccination campaigns at the local level, you will also find in other countries where smallpox vaccination campaigns are there. So this is possible, yeah. Give me a grant, or let's give you a grant and then you do it. Yeah.
I invite you.
And then we try at the same time to submit to a top journal and say, hey, we have because if one of us is first, the other one would say, oh, you know that. Yeah. Yeah. So I do not know, but I can guess. And the reasoning of the person here in front is exactly what we have in mind in terms of, yeah, nobody cares about experts and politicians unless it reveals that they cannot deal with other shocks. And then is a question, why should they know better, by the way, in terms of vaccination? So then the skepticism starts. So this is the example I made with the central bank. So people do not care what the central bankers are. They don't even know that monetary policy exists. But once inflation peaks 20% or 30%, they figured out, oh, maybe some people there made mistakes. And then they, just by recognizing that these people exist, this increases skepticism. So this is, yeah, well, we have to frame our paper in the next months. Yeah, but it will go towards this direction. Hey, many thanks for this extension here. My time management was mediocre, but it's still something I want to have. I finished since weeks, but we are adding data, and then it's also a question when to produce the tables to show and do it to last. Yeah, thanks.
Thank you.
Actually, we were supposed to talk